Now, as we're pulling back here for our measurements, we're also looking around for any obvious signs of dysplasia, and that's any nodularity, any ulceration, any friability, any problem with the way the wall is moving from a peristaltic point of view. And I hope that most people can see there is an area of dysplasia here. It's fairly, I'd say, fairly obvious. If we just pause, let me just let this wall just come here, and then we just pause there. Well, it's not the world's best picture, but you can see at the 12 o'clock position, there's a little subtle area of nodularity. You can almost see where the mucosal sort of puckering in. Now, we're just going to come a bit closer to that position, and you can see it's just here at the 12 o'clock position as I pull back. So there, that's a nice view there. So just here, you can see at the 12 o'clock position, there's certain area of nodularity there, certain area of change there. It's quite difficult to see the 12 o'clock position in that, with the scope like this. So I'm just going to rotate the scope around. So the 12 o'clock is now 6 o'clock, and I'm going to slowly pull back. And hopefully what you can see coming into view now in a second, here we come. Let me just see if I can get a better view of it there. Is in the middle of that nodular, there you go, brilliant. Oh, let's go better. There you go, right there. You can see the complete loss of vascular mucosal pattern, and you can see the vascular pattern has changed as well. Let me just get a nice, there, you can see it right in the middle of our picture there at the 6 o'clock position. That is undoubtedly dysplasia, and undoubtedly possibly even an early cancer. You see here on the right, at the 3 o'clock position now, you wonder whether that's involved as well actually. Just here, there you go, that's a nice view. So there at the 3 o'clock position, you can see another area that's lost its mucosal pattern and lost its vascular pattern. In fact, you can see the vessels are almost fibrous, you can see they're bleeding. So that's an area of dysplasia, and that's also at 35, so that's actually at 35R. To then perform an EMR. So we're going to resect it using the Cook Duet kit and the Via 3. You can see we've marked the lesion here. We know that probably the highest risk area is this bit at 35 here. So we'll probably try and reset that first. We want to take all our marks with us. So here we're going to just come away from the mucosa a bit, angle our scope up towards the 12 o'clock position, and just suck it all towards us now. Once we've got that read out, we twist the lever and apply the band. The snare then goes through the handle. Now you can either take these lesions off either in the 12 o'clock position or the 6 o'clock position. Often we do them in the 6 o'clock position. It depends a bit on ease really. I think in this case it's probably going to be easiest to actually take it in the 12 o'clock position. Let's see. So open the snare please. So you just put the snare past the lesion, like we have done here. We then bring it back over the lesion and then put the nose of our scope up. I've got Elena here who's just going to help me with the scope, so she's just going to hold the scope for me there. And I'm going to push the base of the snare into the rubber band and close me slowly there. You can see the base of the snare is going into the band. And Giselle here is very experienced, so she will tell me now if it's bouncy or snug. And what that means is on the left band. So open the snare just a touch for me. And I'm just going to bring it back a little bit, try and reposition, try closing there. Thanks Giselle, try that. That looks better, doesn't it? Looks like on scope. So now you want to hyperinflate the esophagus, which takes any muscle fibres out of the elastic band. Now we suction down the esophagus and take the tension away. We make sure our snare is straight, which it is. Elena here's just going to hold on to the scope for me now. I do 3 seconds on coag, and then I change to 3 seconds on cut. And we go nice and slowly through. So you ready? 3 seconds coag. 1, 2, 3. Changing over. 1, 2, and 3. Coming through. So just wiggling the snare through there a little bit, and that's great. So that's come through very nicely. We check our base. The base looks fine, and you can take the snare out for me now, please. So there's no obvious bleeding there to start off with. There's no huge areas, there's often no hole, there's no bleeding, so we're happy just to continue our resection. So what we now want to do is do a little bit of, tiny bit of overlap. Now we can either come off to the right here, or we can carry on straight down here, whichever one we want to do. I might do the right wall next, so I'm just going to come above it, just about here, accept that there might be an overlap there, and then just again apply the elastic band, perfectly like that one. The question is now whether that ooze in there is something we need to treat, and it probably is. So the way that we treat a bit of post, so you can see here we have a bit of post EMR bleeding. It's actually quite common to see this. It's nothing to worry about particularly. You can see it's bleeding from that site there. Now, because I've finished the resection, if I hadn't finished the resection, I'd just carry on resecting, so it's not bleeding particularly profusely. But I have finished the resection, so actually what I can now do is just fire off my elastic bands, like this, and just pull the EMR kit out, like this. I now have the cap, I now have the cap actually left over on my scope, which I can now use to help me with treating this bleed. It's just here on the right, coming up to the right, coming up in the 1 o'clock position, just there, that's it. So, some people stay on Swift. Personally, I move over to Softs. Guys, 4.5, please. And we just use the snare tip. So snare tip out, please, guys. That's perfect. We then just look for where that bleeding point is again. So lazy. See, it's just at the 6 o'clock position there. So our snare tip and soft coag. Let's have a look. Might have got it. Let's have a look. We're just going to do a bit of a wash. Looks like it might have done. Looks good, doesn't it? Let's have a look. So we just check that we're happy. There's no fresh bleed in there. That's on this side. That's very nice. There we go. So they're pretty easy to deal with, these little post-EMR vessels. You don't want to get carried away really and start putting clips on or that sort of thing, because actually when you start doing that, that's when you then ruin sort of future treatments. Either there be ablations or resections.